In this module, we will review the image analysis guidelines for the chest and abdomen. Radiographic image analysis guidelines for a PA chest projection state that the thoracic vertebra and posterior ribs should be demonstrated through the heart and mediastinal structures. The lung fields should demonstrate symmetry. Distances from the vertebral column to the sternoclavicular ends should be demonstrated as equal. The lengths of the right and left corresponding posterior ribs should be equal. The mandible should not be demonstrated within the exposure field. The clavicles should be positioned on the same horizontal plane. The scapula are located outside the lung field. The chest should be demonstrated without foreshortening. The manubrium is superimposed by the fourth thoracic vertebra. 1 inch of the apical lung field should be visible above the clavicles. Both lungs from apices to costophrenic angles are to be included within the exposure field. All 10 posterior ribs should be visualized above the diaphragm. A few things I wanted to point out is making sure that your patient adequately rolls those shoulders forward so that we can get those scapula out of the supralateral portions of the lungs. Also, the clavicles. We want to make sure that those clavicles are on the same horizontal plane, making sure those shoulders are depressed. Otherwise, the clavicles will be demonstrated in the apices, and we do not want that. We want to be able to visualize the apices of the lungs. In this presentation, I have provided you the image analysis evaluation guidelines. Also, they are on the Google slide presentation that I have provided you within this module as well. So let's talk about some positioning errors with mid-coronal plane tilting. Mid-coronal plane tilting generally occurs when you have a female with pendulous breasts or, patients with protruding abdomens. They will either tilt forward to hold on to the board, or they will tilt posteriorly, just depending on their anatomy. In the first image here, we have an example of anterior mid-coronal plane tilting. That is when the superior mid-coronal plane is tilted anteriorly. This will demonstrate a foreshortening in the lungs and heart. The manubrium will be situated at the level of the fifth thoracic vertebra or lower, and the apices will be demonstrated well above the clavicles, as you can see in this projection. Just like we have mid-coronal plane tilt anterior, there can be some mid-coronal plane tilting posterior. In posterior mid-coronal plane tilt, the lungs and heart are foreshortened. The manubrium is situated at a level above the fourth thoracic vertebra here, whereas we want it at the level of the fourth thoracic vertebra. And less than 1 inch of the apices is demonstrated above the clavicles. As you can see in this image, your clavicles are sitting directly in the apical portions of the lungs. So we have a case of the posterior mid-coronal plane tilting. So let's take a look at our first PA chest practice analysis. As you can see here, You can look at the clavicles, and they are demonstrated in the apical portions of the lungs. So we have some type of coronal plane tilt here. This is a demonstration of posterior mid-coronal plane tilt. Additionally, the manubrium is sitting at a level of the third thoracic vertebra, whereas we want it at the fourth thoracic vertebra. Also, if you count the ribs, posterior ribs, you can see that we do not have an image that was taken on a full inspiration. So in order to correct these anatomical mispositionings in this image here that we've taken, we need to move the upper thorax towards the IR until the mid-coronal plane is parallel with the IR. And then make sure that we take the image or projection on the second full inspiration. Moving on to our second practice analysis, when you take a look closely here, the patient's manubrium is sitting at the level of the fifth thoracic vertebra. Additionally, the clavicles demonstrate more than 1 inch of apice above them. This is letting you know, or a tells sign of mid-coronal plane tilt, and that is an anterior tilt. In order to correct this, we need to get the patient's mid-coronal plane parallel with the IR. So let's take a look at our third practice analysis. In examining this image, you can see that the right sternoclavicular end here is not equidistant to the vertebral column, and with the left sternoclavicular end, the right side of the chest is actually situated further away from the left side. Also, you can see that the scapula are demonstrated within the lung fields. That's not a great drawing there, but you can see the point. In order to correct this, we need to rotate the right side of that patient towards the IR until their mid-coronal plane is parallel with the IR. Also, we want to roll those shoulders forward and get those scapula out of the lung field. So let's move on to the lateral position, the left lateral chest position, projection. Image analysis guidelines for the lateral chest, left lateral chest projection state that the right and left side posterior ribs should be nearly superimposed, demonstrating no more than a ½ inch of space between them. The sternum should be demonstrated in profile. The mandible should not be demonstrated within the exposure field. The lungs are demonstrated without foreshortening with nearly superimposed hemodiaphragms. There should be no humeral soft tissue demonstrated superimposing the anterior lung apices. The mid-coronal plane at the level of the 7th thoracic vertebra, it should be demonstrated at the center of the exposure field. And the entire lung field, including apices, costophrenic angles, posterior ribs, are to be included within the exposure field. I have included the image analysis guidelines within this presentation as well for the lateral chest. So let's talk about how to identify rotation in a lateral chest x-ray. This is a anatomical graphic demonstrating rotation with the right lung anterior. Let's take a little closer look with an image. There's a couple methods to discerning whether the hemodiaphragm is one is posterior to the other. On an upright patient, gas in the stomach rises to the fundus. So in this image, you can see that the air bubble in the fundus there is right underneath the left hemodiaphragm. So you can determine that because you see this gastric bubble, that this hemodiaphragm right here is the left hemodiaphragm. Therefore, the left side is positioned posterior to the right side. Additionally, there's a second method to distinguish which lung is anterior to the other, and that is looking at the lung tissue that is anterior to the sternum. This lung tissue, when the right lung is rotated anterior, is demonstrated with the left lung rotated left lung posteriorly. The reason for this, is that the right lung is more magnified than the left. Because of that greater OID, there's a greater distance between the right lung and the IR. It also takes less rotation for the lung tissue to be demonstrated anteriorly. So we can assume if we see right lung tissue here, as we do in this image, and we see that gastric bubble, that the left lateral chest or left side is positioned posteriorly with the right side positioned anteriorly. So let's take a look at just the opposite. The left lung positioned anterior to the right. In this instance, when you want to determine whether the left side is positioned anteriorly, typically you're going to see utilize the superior border of the heart shadow. So you can see the heart shadow is here, and it is extending out here. When it's demonstrated anteriorly, and you see that there is some rotation, we don't see a gastric bubble. Yes, we see gas within the bowel system there, but not an actual identifiable gastric bubble. And we don't see any lung tissue anterior to the sternum. The natural process of thinking should be to look for the heart shadow, and I'm more than likely rotated with my left side, or the patient's left side rotated anteriorly. So in order to correct these positioning errors, we need to make sure that that mid-coronal plane is perpendicular to the IR. So let's take a look at this practice analysis. Looking at this practice analysis, we can see that we have some obvious rotation posteriorly. It's the left and right posterior ribs are separated by more than a half of inch. Sorry. There is not any identifiable lung tissue anteriorly. I also do not see a gastric bubble demonstrated very clearly. So my assumption would be that the left side of the patient is positioned in an anterior to the right. Also, we have some soft tissue of the humerus lying and obscuring over the anterior lung apices. So in order to correct all this, we need to get that right thorax positioned a little bit more anteriorly, aligning that mid-coronal plane perpendicular with the IR, and raise those arms up as high as possible so that we can get that soft tissue out of the anterior lung apices.